The next speaker is our Professor S.P. Singh. He is principal at the MLN Medical College, dean and director there at RREO. And he is a wonderful surgeon, does maximum number of surgeries even at this young age. So he is very good at it and does lots of small pupil surgeries, lots of iris claw lenses, secondary IOLs, primary IOLs, and he has got a very good series of subluxated IOLs also. So he has lots of videos available to him, and we have his speech now. Professor S.P. Singh, please.
And sir also has a record of doing maximum number of surgery in a single day in SICS and FECO also, and is a Limca book record holder also.
And thank you so much. Thank you so much. Welcome to this important session of Retropupillary iris lens. As you know, we are also running the PG courses, training program. So in the government institution, though slightly difference, that in the private setup or good setup, you are the expert surgeon. You are managing the things, and very less chances of complication is there. But in the learning phase, in the PG course we are running, so there is as well as our center is also recognized by Government of India as a training center for different specialties. So during learning phase, these complication may happen. So that is important to know how to manage the same seat is very, very important. And this retropupillary iris lens, I would like to say that is a wide range of cases. In any case, that is I have selected some of the complicated case, and you can watch in difficult cases also how you can do this simple procedure, how you can do the secondary IOL, either primary seat and secondary difficult cases. So it has wide range of the cases. That's I'm going to directly start my video presentation in some difficult cases. This is the total corneal opacity with aphakia as well as this mediatic pupil. You can see after removing this opaque lens, you can see how the pupil is dilated, and there is lot of synechiae, peripheral synechiae. Just pull it first to assess whether the pupil can be brought back to its position or not. So in this case, I have decided to do bring a smaller pupil with the help of the Serclass technique of pupilloplasty, in which the 10-0 polonium incision you can take, and you can pass all around at least 8 places with the help of needle, pass the suture all around it, and you can see this is open sky. So don't have much time to leave it this open sky condition for a long time. Only you have to finish the surgery as quick as possible. So you can see after passing Serclass technique pupilloplasty, you can see after passing just tighten it, and then you can bring at least you will be able to constrict the pupil and don't tight at this only thing, and then you can see even this condition in situation how you can do. And this open sky, this is only option. It is very difficult to perform the sky fix in this case type of lenses. Even in this situation, you can see the retropupillary iris lens how nicely within it takes only a few minutes, 1 minute. Within 1 minute, you will complete the procedure. Again, you have to go from the side port rather than open sky. From the paracentis, you can see even this condition, this kind of pupil or iris, you can implant the retropupillary iris and then constrict, and then you can finally tighten it, tighten the knot. But as you know, this pupil is a non-rective pupil, fixed pupil, so the size up should be at least 3.5 to 4 mm is sufficient to prevent any kind of glare, and now ultimately complete it. This another case of corneal opacity with aphakia, as well as there is deficient iris. You can see how much deficient iris is there. You can watch it. So you can just pull it slightly. If there is synechiae is there is how much tissue deficient. Even this condition, you can implant this retropupillary iris in such a large defect, because fixation is iris fixation, this unique fixation mid periphery where the pupil is not mobile. and it's an avascular place. So even and the lens is very stable. I have followed this case and nothing going to happen. And the first enclave, if you enclavate it properly, in the future I have not seen any case in which dislocation or dislocation of lens has been taken place. Only if you learn the real technique, you can see even this kind of condition. In this situation, as I think the only option, no, you can't put the IOL in the anterior chamber. If you can't do the sky fixated, and in this case open sky, for quite long time, because open eyes have a lot of complication. Choroidal hemorrhage may take place, hemorrhage may take place, or edema, macular edema will develop. So you can see, either pull it, you can see how stable. I am just showing the, you can see how much stable even this kind of condition is there. Another, this is the, again, very complicated case. This is anterior posterior, this osteophylloma, partial osteophylloma. This is again, but always hope for the best. You can see how to manage this case and provide a good vision to this kind. Otherwise, the person is thinking, then nothing can be done. This is the case of anterior osteophylloma. Though it is partially inferior placed, you can watch. You can see it is clearly visible. That is a case of anterior osteophylloma. And then do again slightly place the refine slightly inferiorly. You can see. Thus, just remove the lens, try to just remove, sir, in this situation, this is expected, nothing nothing new, yeah, but do the anterior breaking properly, and then again see, ask the assistant to hold the iris, so the iris is a little bit taut, and you can see even this condition, also this is the only option. So this is the beauty of the retrofusion IC396, that is a wide range of cases in which you can perform any case in now you can do, the pupilloplasty can be done to avoid any case of the post-operative glare, etc. You can see just in which direction you can do. Every case requires different kind of suturing, different kind of pupilloplasty. First, just approximate that, and you can do. You can make the pupil in such a defect. The defect was because I know this was a case of osteophylloma, in which this iris atrophied and incarcerated to the tissue, fibrous tissue. You can you can see, hold it from the root of the iris, and then again you can see how you can perform the pupilloplasty in this case. So the lens is very stable. Nothing going to happen in the future also. Only it is reported atrophy. Hardly atrophy is not going to disturb the lens. Lens is not going to dislocate. I have not seen till in my own cases in which I have enclavated properly. And you can see how the pupil can be the round pupil can be made and ultimately you can complete it. Then another difficult case, this is this is a case of the posterior dislocated lens was moving, and the pupil much more dilated. In this case, in even this dilated condition, how to do the this implant the retropupillary iris lens? You can see that lens is posteriorly moving, and then I think it is going posteriorly. So I just place this infusion, so a lens comes forward. So this is not required in this case to go the posteriorly. It comes out automatically after an infusion. So lens has been removed, and you can see again put it with sedated microphages, slightly pull it, and just bring whether it will be bring back or not. So you can see even in this much dilated, because the inclination takes place in the mid periphery. So you can see, you can pull it. You can see this kind. And the only trick that has my speaker given, that is incisor is given to the post limbal and is short length. So you can include the mid periphery rather than enclave it towards the periphery of the iris. And then with the another technique, this single pass for 4-throw pupilloplasty, you can with the side port, the Ayuna and Dr. Amar Agarwal, there are various methods. This 4-throw pupilloplasty advocated by Dr. This, and then you can see the so earlier the strips are not technique also. There are so many techniques, but in this situation, in so much dilated pupil is there. So at least my aim is not only to tell only iris class. You have to manage in toto. How does these type of different cases it comes? You came across to these type of cases. You have to manage everything, not only to put the lens, escape fixation, iris ka, anything. But you have to know how to comprehensively manage the situation and manage the case. So you know this is another aphakia with this old case and with this people dilated, much more dilated. In this case, you know, I am going to demonstrate another technique. Earlier in surclass technique. Earlier I demonstrated in surclass technique in the open sky. Now I am going to demonstrate this another, though it is difficult, but you can do the surclass technique in which with the side port you can straight needle, make it slightly curved, so you can pass through the one port all around 1 to 2 meter away from the pupillary margin and at a distance 0.5 mm at the border. And then from this one side port you can remove this lens or this needle, retrieve it. You can pass through the cannula or the needle as a guide, and you can bring back this needle. You can make 2 or 3 or 4 places, different places. If you take multiple entries, then it requires very only at a time you can pass the suture at 2 or 3 places, then retrieve it, again go for another port, but in simultaneously I have done in only 3 port, making 3 port from the opposite side, pass all around this pupillary margin, and then the needle is retrieved. You can see both this at one port, both the end has been just removed, and you can see again in this much dilated pupil, you can see again implant the push iris ka lens with the same principle, and then you can tighten it. You can see how you can bring back the pupil in such a difficult case. But once you know, if you do some cases, then you can do other cases also. This is another, you can see this is the case, and a very difficult case. Earlier, when the person referred to me, I thought that this is the only remnant part of the iris is there. What to do? Earlier, I decided to do in this case is square fixated lens, and then I started doing the surgery. Then I changed my idea. You can watch what to do in this case. This is again very difficult gone case. You can watch it once after making the tunnel, and I injected the fluid. I just make it. Then you know, after injecting it, then pupil is moving and unfolding. Then ultimately the diagnosis changed. That is nothing but the severe case of severe ardodialysis. You can see then how you can and the suture the ardodialysis case. In this case, earlier that's only a small remnant was visible. But when I started injecting the fluid inside, the iris start unfolding, and then I thought this is nothing, but this whole iris is curved at one particular point, and you can see in such a case what to do, how to manage this case. In this case, you know, different places, make a scurril tunnel at different places rather than making a flap, and that in that tunnel you can just pass the different places. Again with the hip, you can do the metasus also, or the separate this double arm needle. You can take it from this root of the iris when capacity from the another end as a needle 26 gauge 27 gauge needle. It helps to retrieve the needle, and you can go different multiple places, and you can see even this case the pupil can be made. You can earlier, you know, this is the real challenging case, but you have to accept the challenge of the patient, challenge of the cases of the eye. Whatsoever you can see, the pupil can be made. And again, I am going to again demonstrate further in this case what to do further, which kind of lens have to put in this case. You know, in this case you can't put the into ACI wall. Only you can think even in this case retropupillary lens can be placed very well. This last case, another case, you know, this is the case of this is a rare case iridocysis, in which, you know, rare case iridocysis, very few cases have been reported, and in which again the Jonus are a baby, total lens is almost dislocated, though it is placed in the anterior vitreous face. This is the ardositis case of ardositis, in which the it is moving the entire surface of the as a stent is moving. You can just bring the nucleus in the antechamber and just remove it, and you can see this is the rare case of the this ardositis case. Whole stent is moving the antechamber. What to do in this case? Again, I plan and I follow this case again in even this situation. Though you have been reported iris atrophy, etc., but you can implant anything. Tissue, at the tissue is there, pigment, there is loss of pigment, but the tissue is there, remain. So even this rare case, you can do the retropupillary iris analysis. So that's our main aim of this course is just to cover everything, and this is the beauty of this kind of lens. Stability, it is very secure. This kind of iris lens very safe, efficient. And the lens is stable, having very less complication of this kind of lens. If you know real technique, there is no mobilization, there is no distentation of the lens, no drop of lens, and the macular edema also less in comparison to the SF fiber. As you know, that surgery is a very lengthy surgery, and it takes very short time. So of course, and you know, the chronic inflammation of this is less, because as the lens is enclavated in the mid periphery, whereas what happens, the scan fixes cylinder, you have to go through the ciliary body. Then there is a lot of chronic inflammation may persist, that may lead to the macular edema. It is more than the retropupillary iris paralysis. So this is thank you very much for your patience.